Yeah, my name is Heun. I'm a consultant psychiatrist. Welcome back. I haven't talked for a while. I'm editor of Global Psychiatry Archives and invite you for uh, submitting a paper. Today I will talk about the series of mental health disorders, and I'd like to come to the management of panic disorder. So I try to make it reasonable for people who are interested and young trainees and nurses and the patients who might be interested. Anyway, usually in the management of panic disorder, it's a combination of psychopharmacotherapy and psychological treatments. Usually it's better than a single approach. Initially, it depends a little bit on the preference of the patient. Some people prefer psychotherapy, some people prefer medication, and sometimes have their experience from themselves or from someone in the family. So that's a bit of the choice. And the pharmacotherapy is usually SSRIs. SSRIs means serotonin reuptake inhibitors, and other antidepressants like SNRIs, which are serotonin noradrenaline reuptake inhibitors, or benzodiazepine or tricyclic antidepressants. And the other ones are monoamino oxidase inhibitors. So you see, sometimes this is, when you look at monoamino oxidase inhibitors, then it's a definition which is based on the function. However, tricyclic antidepressants, it's more or less on the structure of the system. So what you see, there's lots of inconsistency in medicine, but that's the history of that. So serotonin reuptake inhibitors, so what's in the UK, it's citalopram, escitalopram, paroxetine, sertraline, and they all can be used for panic disorder. Usually it has been found by the fact that depression and anxiety always running a bit together. Right. It's also important to consider how much it affects the patient and what causes. Are there any triggers or are there no triggers? Can you avoid triggers? How frightening is an episode? So let's say it that way. If someone has a panic attack for 5 minutes every seven months or 7 weeks, you would certainly say maybe you wouldn't want to take daily medication. However, if there are any conflicts in the family or any conflicts in the person or in the environment, then psychotherapy might be helpful anyway, but it might not be just for the panic disorder. It might be helpful in other ways as well. Right, usually when you take SSRIs, serotonin reuptake inhibitors, then you start low, then you increase slowly, and then you may take a while, but then you would try on the highest dosage for a while. Other medications, they are venlafaxine, names are imipramine, clomipramine, or phenelzine, which when you look at the monoamino oxidase inhibitors, or reversible in monoamino oxidase inhibitors like mopramine. Benzodiazepines are usually quite well tolerated and sometimes quite well liked. However, the advantage is that they can easily, because they work so nicely and calm down, cause addiction. Addiction usually means that people want more and the effects is less, and the effects wanes out and you have to take more and more to get the same effects. And at some point anxiety can be caused by withdrawal symptoms. So that's a problem. You need more, the effects get less, and you may get withdrawal symptoms, which then cause panic attacks. Right. Some medications are less efficient than others. There might be buspirone or mirtazapine, reboxetine, antipsychotics. However, sometimes antipsychotics might be quite helpful to some extent. Right, so second line treatment would be other antidepressants, would be second generation antipsychotics, and if it works, you would keep the medication for quite a while, and usually for a couple of years, and then you might discontinue the medication, and sometimes the symptoms come back. So it might be either that these are then withdrawal effects, which are quite rare, but most likely there are re-emergence of symptoms in people who wouldn't have other problems than, because it's simply the medication covers the symptoms. So in this respect, the recurrence of symptoms is not a new disease, it's that the medication worked. Right, so if there's an emergency, and panic attack can be very violently perceived by patients, usually you would try to reassure the patients and try to be calm, stay with them, be calm yourself, and usually most panic attacks resolve within 30 minutes. If it's severe and distressing, you could use benzodiazepines, which usually help quite well. So they usually cause the anxiety to go. However, if it's taken very often, it can lead to very addiction, and people try to take more and more benzodiazepines, even when they just fear anxiety. So that's getting a vicious circle. People fear anxiety, take medication, and then they get withdrawal symptoms, fear more anxiety, take more medication. Right. However, sometimes, you might have physical health problems, and you have to, especially when it's the first time, pheochromocytoma or heart problems or whatever, lung problems might cause physical symptoms, which are seen as symptoms of panic disorder. So usually, at least once at the beginning, one should have a decent physical assessment. Right. Then you have psychological. So we talked about the medication. Now we have psychological help, which is usually CBT, usually behavioral methods, which might be relaxation, control of hyperventilation or avoidance of hyperventilation. And then sometimes it's what we do, flooding, that people try to, challenge the anxiety and see that the anxiety will go. So the other thing is teaching about it's a cognitive approach in CBT. It's about teaching about physical responses, how anxiety is presented, and trying to modifying these panic attacks and these catastrophic thinking. Right, psychodynamic psychotherapy might help if, let's say that way, if that triggers, and then the emotions which might cause panic attacks. But usually it's more or less that CBT might be the first choice. It's easier and it's more available. Usually, panic disorders are very common in generalized anxiety disorders, in depression. So that's usually quite easy because, or social phobia, OCD, because usually the medication effect is more or less the same. Chronic alcohol abuse may either be triggered by panic disorders because alcohol calms down, but on the other hand, alcohol is very addictive, and withdrawal effects can easily cause panic attacks. Right. So usually when people are seen with a GP and with a psychiatrist, they usually have a long history of panic attacks. They usually have been untreated for years, and with treatment, the outcome is much better. So let's say it that way. If it's if it's treated in the first 2-3 years, the anxiety or the panic attack might go. However, in the long term, it will be 50% who will have only mild symptoms. Usually, if it's a long story which has been run with very severe initial symptoms, agoraphobia, which means the avoidance of open places, people in poverty, little education, and long duration of symptoms, they usually panic more because they have more anxiety about the panic attack, which then paradoxically triggers another panic attack. And it's also the social network and the presence of personality disorder, which might be positive and the other one might be negative. Okay, so if you're interested in some education like that, please look at our website, YouTube channel, Global Psychiatry Archives, and we previously had a video which explained the panic disorder symptoms a bit more precisely. Today we focused about the management. So have a nice evening, nice Sunday, and I hope you enjoy that. Thank you.